Picture this, a burning hole in the stomach lining. And the moment that pain becomes rigid and board-like, well, it's officially broken through. Think about the sheer visceral reality of that for a second. Acid literally eating a crater right into the gut wall. That sudden rigid pain, it isn't just discomfort, guys. It is a life-threatening, red flag emergency that is screaming for immediate action. All right, let's jump right in. Welcome to this explainer on peptic ulcer disease, or PUD as we usually call it. Now, if you're prepping for the NCLEX, you already know this is one of those highly tested, absolute must-know med-surg emergencies. Today, we're going to do a rapid-fire, high-yield review of exactly what happens when the stomach's defenses fail, how you can spot the distinct signs of different ulcers, and what your absolute priority nursing interventions need to be when things go south. So let's break down how an ulcer actually forms in the first place. Peptic ulcer disease is fundamentally a defense versus acid problem. It's a literal turf war in the gut. Step 1, the barrier breaks. The two absolute biggest culprits here are H. pylori infections and the heavy use of NSAIDs or aspirin. They basically wreck that protective mucus and bicarbonate layer. Then, step 2, acid attacks. Without that shield, stomach acid and pepsin wash right over the unprotected mucosa, which leads us to step 3, an ulcer forms. The acid literally erodes the lining, creating a crater. And finally, step 4, the one we really worry about, the complication. The ulcer can erode deep enough to hit a blood vessel, which causes a massive bleed, or it can eat entirely through the stomach or intestinal wall. And that right there is what we call a perforation. Now, food is actually your ultimate diagnostic clue to figure out which type of ulcer your patient is dealing with. You absolutely have to know the difference between gastric and duodenal ulcers. With a gastric ulcer, to look at in the stomach, the pain actually gets worse with food, usually about 30 to 60 minutes after eating. Because of this, patients often lose weight because they're literally avoiding eating just to dodge the pain. The memory hook I want you to use here is gastric equals greater with food. On the flip side, with a duodenal ulcer, which, by the way, is the most common type, the pain actually gets better with food, but then gets way worse 2 to 3 hours later when the stomach empties or even in the middle of the night. These patients often have stable weight or they might even gain weight because they're eating to relieve the pain. Your memory hook for this one, duodenal equals down with food. Seriously, lock those two hooks in for your exam. Moving on, let's look at the classic clinical clues. The absolute hallmark presentation is that epigastric burning or gnawing pain. But, as a nurse, you are always hunting for complications, right? So if your patient has melena, which is that black tarry stool, or hematemesis, specifically coffee ground emesis, those are massive red flags. I mean, sirens going off. It means the ulcer has hit a vessel and your patient has an active GI bleed on their hands.
And speaking of red flags, that brings us to the ultimate killer. Perforation. If your patient suddenly develops severe abdominal pain and their abdomen becomes rigid and board-like, guys, the ulcer has just broken through the wall. Stomach contents are literally spilling into the peritoneal cavity, and that causes peritonitis. This is a massive surgical emergency. You need to make the patient MPO, start IV fluids, and notify the provider's stat. I cannot stress this enough. Rigid and board-like is your absolute danger phrase.
So how do we actually find this crater and, the bug causing it? An EGD or upper endoscopy is the absolute gold standard here. It lets the provider get a direct visual of the ulcer, take a biopsy, and they can even treat active bleeding right then and there, which is pretty amazing. Alongside that, we have our H. pylori tests, things like the urea breath test, stool antigens, or a biopsy. This is how we confirm if that #1 infection cause is present, so we can go ahead and eradicate it. Okay, so what is your role in all this? Let's walk through your priority interventions, and we are ranking these strictly by priority. Number 1, assess for hemorrhage and perforation first. You gotta check those vital signs for shock and feel for that rigid abdomen. Number 2, if they are bleeding or perforated, jump straight to your ABCs. Secure large bore IV access, push those fluids, and prep them for an EGD or surgery. Once the life-threatening emergencies are managed, we move to number 3. Give acid-suppressing medications and H. pylori therapy, and of course, stop any NSAIDs. Number 4 is pain and diet management, just keeping them comfortable and removing any irritants from their diet. And finally, number 5, educate. Teach the patient about medication adherence and avoiding NSAIDs long-term to make sure this doesn't happen all over again. To actually heal that mucosa, we need the right pharmacological toolkit. PPIs, like omeprazole, are given before meals. They block acid production and give the ulcer a chance to heal up. Now, if H. pylori is the culprit, we bring out the big guns, triple therapy. And this is absolutely crucial. You must educate your patient to complete their full antibiotic course to totally eradicate the infection. Otherwise, the ulcer is just going to come right back. We also use H2 blockers, like famotidine, as adjunct therapy to further lower those acid levels. All right, it is time for a test yourself
NCLEX moment. Drop your answer down in the comments for this one. A client with a peptic ulcer suddenly develops severe, sharp abdominal pain with a rigid, board-like abdomen. Do you suspect A, expected ulcer pain, B, constipation, C, perforation of the ulcer, or D, hunger pain? 3, 2, 1.
And the correct answer is C, perforation of the ulcer. If you got this right, awesome job. The rationale here is literally life-saving. A rigid, board-like abdomen combined with sudden, severe pain is the classic hallmark sign of a perforation leading to peritonitis. It is never just expected pain. It's a full-blown surgical emergency that requires you to notify the provider immediately. Let's do one more to lock this in. Question 2. A client is prescribed triple therapy for an H. pylori-associated ulcer. Does this regimen include A, corticosteroids, B, a single antibiotic only, C, antacids and laxatives, or D, 2 antibiotics and a proton pump inhibitor? 3, 2, 1. The correct answer is D, 2 antibiotics and a proton pump inhibitor. Triple therapy is super specific. You absolutely need the 2 antibiotics to completely wipe out the H. pylori bacteria, combined with a PPI to drastically reduce stomach acid. That way, the mucosal creator actually has an environment where it can heal properly. To wrap this explainer up, just remember this one golden rule. Food tells you the type, and a rigid abdomen tells you it perforated. Gastric is greater with food, duodenal is down with food, and board-like means get to the OR right now. But think about this. What happens if that perforation goes unnoticed for hours and systemic shock actually sets in? Well, that is a deadly sepsis cascade, and we'll be breaking that down next time. If this made it click for you, subscribe. We're covering one killer med-surg topic every single day until you pass the NCLEX. Keep studying hard, and I'll see you in the next one.